So the repair program was designed to show target engagement with CNM-Au8. We tend to get the same two questions from people. Firstly, how can you prove that these little gold nanocrystals actually get to the brains of human beings? And if they do get to the brains of human beings, how can you show that they actually have the positive effects on energy metabolism that you say that they have? And short of putting a catheter into people's brains and then, actually measuring real time, things like NAD, NADH, ATP, which IRBs frown on, the best way to do that is with this technology called phosphorus 31 or P31 MR spectroscopy. So we worked in conjunction with the University of Texas Southwestern. They have a translational neuroscience research center, which is outstanding. They also have one of the few 7 Tesla magnets in the country. And they also have experts in MS and Parkinson's disease that we work closely with. So we were very fortunate to do this, to work with them. They also have a radiophysicist who designed the head coils and did the analyses. So that was actually quite fortunate. So what we did is we imaged people at baseline, and then we re-imaged them after at least 12 weeks of exposure to CNM-Au8. And there was no placebo control, so everybody was on active. But importantly, we re-imaged the MS population after at least 6 weeks of withdrawal off of CNM-Au8, which is an important, I think, validator. So what we found was, so we had to, because of the pandemic, of course, all research at UT Southwestern was essentially shut down for a year. So we weren't able to fully enroll each of the Parkinson's disease and MS cohorts. So we had a pre-specified integrated analysis where we combined the two populations for the primary endpoint. And then, of course, we looked at each population individually. So we presented the Parkinson's population last month at the International Movement Disorder Society meeting. And we presented the MS population just now at the ECTRIMS Congress. So we were very happy to do that. So to get to the bottom line, what we found was a statistically significant increase of 10% in the NAD to NADH ratio in the brains of these patients. Now, what is NAD NADH ratio? So it turns out that NAD, nicotine adenine dinucleotide, and NADH, nicotine adenine dinucleotide hydride, are the redox partners that actually drive ATP formation in cells. So ATP, adenosine triphosphate, is the sort of monetary exchange of energy within cells, but ATP essentially does everything in cells. We are totally dependent on ATP for metabolism, for life. In fact, we actually metabolize our own body weight in ATP every single day. Can you believe that? That's an amazing fact. Let me just say that again. We metabolize our body weight in ATP every single day. So the lack of ATP production is a critical factor driving neurodegenerative disease, including progressive MS. So what we do is we actually allow cells to make ATP in the setting of oxidative stress. And that's reflected by this NAD to NADH ratio. It turns out in these redox pairs, NAD is what actually drives ATP formation. Even though NADH gives the first electron in the electron transport chain, it's NAD that drives the process because NAD tells the cells that we can make ATP now. And if you have too much NADH, you actually have what's called reductive stress. So too much NADH is bad. So NAD drives this redox pair, which actually drives ATP formation in cells, both in aerobic glycolysis and in oxidative phosphorylation in mitochondria. So what we showed was a 10% increase, statistically significant 10% increase in NAD to NADH. Now you say, well, that doesn't sound like a lot, but actually it is a lot. So if you think about normal aging, we lose about 0.5% of our NAD to NADH ratio per decade. That's based on P31 MR spectroscopy imaging of normal healthy people. So 0.5% per decade is what we normally lose. And I'm a lot older than you are. So my NAD to NADH ratio is a lot smaller than yours. So I'm just trying to keep up here. So what we showed was a 10% increase in these patients, which actually reflects, think about this, it reflects 20 decades of normal aging. So, of course, these people aren't normal because they have neurodegenerative disease, they have PD or MS, and of course, we know that their NAD to NADH ratio is lower than normal. So, again, we were very, very gratified with these data. It shows target engagement. It shows that CNM-Au8 actually does have, gets to the brains of human beings. It does have really profound effects on the ability of brains to make energy. And that's exactly what CNM-Au8 does. It actually allows cells to make ATP in the setting of stress, oxidative stress. You name the stressor. We've done preclinical models to look at this, and CNM-Au8 has really profound beneficial effects in making ATP in the setting of stress. So we were very gratified with the data. It's the same. They were sister studies. The PD and MS studies were exactly the same. That's why we could, that's why we could combine the data for the primary endpoint. So we showed the primary endpoint data at the International Mood Disorder Society meeting, and we showed the PD data. Now, if you look at the PD and MS populations individually, they look, the trends are exactly the same. In fact, I think the amount of NAD increase in the PD population was something like 14%. I think the amount of increase in the MS population was something about 8%, something like that. And overall, it was 10% for the combined population, which is really impressive if you think about how NAD and NADH, they're tightly regulated, how these things actually work. So if you can think in 12 weeks, we actually increased an NAD to NADH ratio in the brains of these human beings by 8 to 10%. It's amazing. So yeah, we presented the individual PD data along with the combined data. And here at ECTRIMS, we have a poster, we actually have a platform presentation, which I'll be presenting on Friday, which actually presents the integrated data and the MS population. Well, the study was not designed to look at clinical effect, right? Because that would require a lot more people, and there's only so much scanner time. We did actually show the modified MSFC data for the MS population. But of course, it's only 12 weeks and it's only really 12 or 15 patients. So you can't and it's open label. So I think you have to take the clinical data with a grain of salt. That being said, Dr. Benjamin Greenberg, who was the MS expert at UT Southwestern, he was actually kind of impressed with the data. If you actually look at sort of week 12, and you look at the the composite of the modified MSFC, the modified MSFC is composed of 4 subscales. You have the low contrast letter acuity, which tests vision. You have some of the modalities test, which tests working memory. You have 9-hole peg test, which tests, upper extremity cerebellar motor function. And then you have the time 25-foot walk, which tests, gait. So those 4 tests together make up the modified MSFC. And we kind of looked at the composite, right? The composite score, which people have been using lately. So when you look at that and you look at week 12, there's sort of a Gaussian distribution around 0. But as you go from week 12 to week 24, week 4 is a Gaussian distribution around 0. But as you go to week 12, there's actually an improvement in the composite score, in the population. So yes, they got better. Would I put a lot of faith in that? No, I really wouldn't put a lot of faith in that. I mean, we're gratified that they're getting better, but come on, it's open label. It's a very few people. Ben was impressed, but I'm not sure I'm so impressed anyway. But we will have clinical data. We have clinical data coming soon. We have a phase 2 study in ALS called Rescue ALS, which we'll be reading out before the end of the year. So we'll have proof of concept data in ALS, which is in some sense, a much tougher disease than progressive MS. And we also have MS data. So we have the Visionary MS study, which is ongoing in stable relapsing MS patients. So we're taking patients on therapy and adding CNM-Au8 or placebo to patients who are controlled on their DMT and looking for neurological improvement. And we showed these. We have a poster at this ECTRIMS showing the current amount of blinded data we have, showing that the population as a whole actually is improving. Now, we can't tell you why they're improving yet, but they're definitely improving. So right now, things are looking very positive, and we'll have more data as time goes on, and we're very excited about CNM-Au8.